Well, good morning, and first of all, thank you to the organisers of today's meeting for inviting me to speak at your conference. I've pre-recorded this, but I will be available for the question and answer session afterwards. My name is Professor Tom Wainwright. I'm a physiotherapist by profession and currently work at Bournemouth University as a professor in orthopaedics. I've had an interest in enhanced recovery for over 15 years, and today I'm going to talk about ERAS in spine surgery and how it can contribute to improving the quality of care. Now, I've worked within enhanced recovery as a clinician, as a manager, as an academic, and also as an external consultant helping other organisations to implement enhanced recovery. I first became involved in enhanced recovery back in 2007 as the manager of our orthopaedic department. We ran a service where we treated approximately 2,000 joint replacements every year, both hip and knee replacements. And we instigated a new enhanced recovery pathway, which saw our length of stay reduced from 8 days down to 4 days in the period of 3 months. So a 50% reduction in length of stay. And since this time in orthopaedics, we've seen length of stay reduced further down to now where day case surgery is common in many hospitals. What's interesting here though, if for all of the literature that we read, if we were told there was a robot, there was a new spinal instrument or screw or type of approach that could half length of stay, we'd all be extremely interested. And that's what lit my enthusiasm for enhanced recovery. It was a multimodal approach that could deliver significant benefits to our patients and improve the quality of care. And what we've seen over the last 15 years is that enhanced recovery has been hugely successful at improving clinical outcomes across the elements of quality. Length of stay is often used as a proxy of quality in terms of enhanced recovery, and we've seen reductions across hip and knee replacements. Readmissions have reduced or not increased where they're already been low. Complications related to the surgery have also decreased. Mortality rate, although not frequent, has been shown to reduce by some excellent work by Mike Reed's group in Northumbria. Patient-reported outcome measures and patient-reported experience has also improved. And for many hospitals, enhanced recovery has delivered economic and operational efficiencies. So the question today is, can the same quality of care improvements be delivered in spine surgery? Well, I think they can, and I think we're seeing evidence of this, especially since I wrote the first article in this area back in 2015, where we talked about the potential for applying enhanced recovery principles to spinal surgery. At about the same time, there was the first examples of early implementation of enhanced recovery in spinal surgery. And the graph here shows the results from a district general hospital in the UK, where they implemented enhanced recovery for the whole of their elective spine service. Length of stay reduced by 3 days over the study time period, with no changes to patients or surgeons or any other factors, but instead just optimisation of operational efficiencies and the introduction of some key elements related to enhanced recovery, which I'll talk about in a moment. So, as an overview of what I plan to cover today, I hope enhanced recovery is something you're all familiar with, but if you're not, I'm going to provide a bit of background and an introduction. I'll then talk about the underlying principles of enhanced recovery, talk specifically about the components related to spinal surgery and ERAS in spine surgery. And then I'll give some examples from physical therapy practice to show you that we must examine all elements of our care that we provide patients to ensure that we're doing the best that we can for their care pathway. So what is enhanced recovery? Well, it was first sort of coined the term and first introduced under the sort of name fast track surgery by Professor Henrik Kellett. He was a general surgeon from Copenhagen in Denmark. And in the late 1990s, he turned his current pathway of care for his patients on its head. He questioned why he was starving patients for long periods before and after surgery. He questioned why he needed to give them a big general anaesthetic and why he needed to give them lots of opiates as their analgesia. And when he started to change this, he got radically different results for his patients. He defined enhanced recovery as an evidence-based approach to care. It is designed to prepare patients for, reduce the total impact of surgery, and help them to recover more quickly. It is a multimodal approach similar to that of care bundles. And what he found by introducing and questioning the dogmas and traditions of surgery was that patients recovered much quicker. He explained this by looking at surgery as a stress response, and he hypothesized that with enhanced recovery we would reduce the surgical stress response. This will enable a quicker return to recovery after surgery. This graph here shows the traditional recovery curve after surgery in the red line, and then you can see that if you implement this multimodal intervention based on a multimodal approach to pain relief, early mobilisation, early return to feeding and nutrition, you would reduce the surgical infarct and allow patients to recover quicker. And of course, in recent years, we're now trying to optimise that further with prehabilitation, and we're also trying to get patients to recover higher than their baseline activity levels. With all of this early work, Henrik asked 3 questions of his clinical team and within his research. Can every elective operation be ambulatory? Why is the patient in hospital today? And what is it that we cannot control? And these 3 questions are still really relevant today. And as we look to apply enhanced recovery to different procedures, such as those within spine surgery, we should ask ourselves these questions. If at present the operation isn't day case, if they're staying longer, what are the reasons for why they're staying longer? Is it pain? Is it due to immobility? And how can we try to influence these things? By changing our practice through earlier mobilisation or a change of analgesic regime? What can we control to make the improvements? This famous diagram was also produced in the early 2000s. And I think, again, it's a good reminder that at its core, enhanced recovery is simple. It is a multimodal, multidisciplinary intervention. For it to work, the surgeon, anaesthetist, nurse, physios, all other allied health professionals and support professionals and managers must all play their role, along with the patient playing an active role in their recovery. And the aim is to get an accelerated post-operative recovery with reduced morbidity after surgery. And this is done through preparation before surgery, better information, optimisation and a thorough assessment, attenuation of the surgical stress response with minimally invasive techniques, regional anaesthesia and a multimodal approach to pain control, early mobilisation and early rehabilitation, and patients getting dressed, eating and drinking normally as fast as possible after surgery. And these components, when we talked about them like this, of course we could hypothesise that they could be applied to spine surgery. And this rationale can be strengthened by the following points. There's strong evidence for enhanced recovery across a range of musculoskeletal surgery, hip, knee, shoulder, for some examples. And there is a strong theoretical case for improving spine surgery outcomes by introducing enhanced recovery principles. And over the last 3 to 4 years, we've seen lots of new publications and accounts from across the world of people implementing enhanced recovery for a range of spinal and neurosurgical conditions. We also have to acknowledge that within our current practice, these graphs here show length of stay across different trusts within the UK. There is variation in our outcomes that show that there is scope for improvement. This variation in length of stay seen across these common surgical conditions in the UK is not due to case mix, it's due to differences in the perioperative care pathways that these hospitals use. So, returning to this slide we saw earlier and the example from Taunton. What's interesting about the study in Taunton, it was a typical UK district general hospital, not a teaching hospital, a typical hospital with typical resources. They used the experience of implementing enhanced recovery in hip and knee and transferred that learning across and applied it to all of their elective spine operations. What they found was over a 50% reduction in length of stay, a reduction in readmissions, and a really high rate of patient satisfaction. So how did they do it? I think one of the key points I take from reading the paper is the importance of standardisation within their pathway. They also gave an expected day of discharge to all patients, and they started to think of their patients on different pathways. They were aware that the operation notes would often give quite complex descriptions of the different surgical procedures. And although this was instructive to the surgeon and those surgical colleagues, it wasn't particularly instructive to the nurses and the physios on the ward in order to know how quickly they could rehabilitate or how quickly they could start to go home. So they produced this nomenclature, and along with this nomenclature for all the different types of procedures they did, they gave an expected day of discharge. And the patients were told this before the operation. They're much more likely to go home after 1 or 2 days if that's their expectation, than if they're told they're going to stay 5 days. If they're told they're going to stay 5 days, it's very hard to persuade patients to go home earlier, even if they could do. So this organisational learning from hip and knee was important, as was the production of a simple and generic pathway for all spine patients. This pathway, elaborated here, included process and clinical elements. They introduced some clinical elements which they hadn't used before, such as the use of tranexamic acid, which has been well proven now in hip and knee replacement. They also had some equipment, such as a surgical microscope, which allowed more minimally invasive techniques. But most of the things, such as correspondence, operative list planning, discharge plans, changing of early mobilisation, are process elements, which excitingly are often within our gift to change if we want to and if we can organise ourselves to do so. This is an important point, and I'd urge you all to think about this when you're thinking about how to set up enhanced recovery for your different spinal procedures. At the moment, we may have an absence of procedure-specific advice for some of our spinal procedures. But what we can do is we can ensure that we consistently provide the pathway we currently intend to do. This is really important, because if we set up an enhanced recovery pathway, it's important we deliver the same pathway every time to all our patients. We need to remember that enhanced recovery is a vehicle which will allow us to improve patient care and improve quality. Enhanced recovery is the clinical decisions, it's the evidence-based medicine that tells us the components which we need to introduce within our pathway. But those on their own are not enough to change care. We need the process and system changes alongside that allow us to affect our patients. So you need to do the right things in the right way every time for our patients. And it's amazing how important this is, but how often clinical teams don't focus on the process and system changes, but debate for a long period of time about the drug or the procedure to give, when actually what's probably more important is that we reliably deliver what we intend to do every time for every patient. There are some detailed analysis and detailed examples of different pathways for different types of spinal procedures in the literature. I give this example for idiopathic scoliosis as one such example. This is quite different to hip and knee replacement surgery in terms of the patient group and also the complexity of surgery. However, the team from the US here, in a couple publications, showed that they could reduce length of stay and improve other measures of quality by introducing enhanced recovery to their patients. What's great about this pathway, there's a link at the bottom, and there's an interactive page on the internet which allows you to look at all of their protocols and pro formas for introducing this pathway of care. I choose it as one example about where, in a quite different type of procedure and surgery from elective hip and knee replacement, the same principles of enhanced recovery have been found to be successful. So where does this leave us? Well, there's strong evidence to support the adoption of ERAS pathways across a broad range of non-spine surgery procedures. There's emerging research evidence to suggest that ERAS principles can have the same effect in spine surgery. And we acknowledge that specific ERAS guidelines in this area may be useful. And I was lucky to be part of a team led by Bertrand de Bono from France to produce the first consensus statement for spinal surgery and enhanced recovery. This was published in the Spine Journal a couple of years ago now, and it goes through the key recommendations using the grade criteria and our learnings from other enhanced recovery pathways of a generic enhanced recovery pathway for multi-level lumbar spine fusion. What's interesting about here is that this can be used as a basis to then optimize and develop different procedure-specific pathways for other types of spinal surgery. And if you're interested in this area, I'd urge you to have a look at that guideline document. What I've been doing from a physio perspective is looking at how physical therapy involvement in a spine pathway can be improved. I'm always asking the question, what can be further optimised and what can be improved? And I give these an example within physio practice that I would encourage you to take back to either your surgeon, your anaesthetic or your nursing professions to see what things you could question about your practice and improve for our patients going forward. So first of all, prehabilitation. This is the use of exercise, nutrition and psychology before an operation to optimise the outcomes and rehabilitations of patients after the operation. This is an attractive concept, but spine surgery, like many other types of surgery at the moment, there's insufficient evidence to make a recommendation prehabilitation is essential for all patients. What I think we may find in the future is certain elements of prehabilitation will be relevant to specific patient groups for different types of spinal surgery. So for instance, an elderly patient with multi-level degeneration of the spine having fixation, they may be particularly deconditioned, and therefore a physical and nutrition intervention may help their recovery after surgery. This might be different to a younger patient having a multi-level lumbar fusion who perhaps has chronic pain, is very anxious, so they might need a more psychological input before their surgery. So there are exciting areas for future research and work. Preoperative education is a mainstay of enhanced recovery, and whilst the specific effect of its intervention to reduce length of stay has not been found, we'd recommend that it's a good thing to do. You need to ensure your patients are well prepared and understand what they're about to experience through their pathway. Of course, if you're going to tell them what you're going to do, you have to make sure that you do that every time for every patient. So good pre-op education needs to be based on the fact that you have to standardise your pathway first. Otherwise, what you're telling them may or may not happen as you describe. Early mobilisation and early physical therapy are recommended. We need to get people moving as quickly as possible, and we've seen this come in across all of the surgical specialties and procedures where enhanced recovery has been introduced. However, there are things we can improve. We looked at different education leaflets that were given to patients about their rehabilitation after spinal surgery. What we found was, using this Discern tool, which is a measure of quality of patient information, there was massive variation across hospitals in terms of the quality of information we give to patients. This seems like something easy that we could fix in all our hospitals if we wanted to improve the information we give to patients so that they recover quickly. So I urge you to have a look at this publication and take the examples we take from the exemplar units and apply those to your own patient information leaflets. And lastly, we conducted a critical analysis of exercise prescription and return to activity advice that is provided to patients in information leaflets. There is wide variability across hospitals for the same procedure. We looked at lumbar fusion surgery and found a massive variation in what my physiotherapy colleagues and surgical colleagues told patients they could do at different time points. This is confusing for the patient and it's confusing for the therapist. I think there's much work to do here that we could better understand the rehabilitation pathways and progression pathways of patients post-discharge as they recover from spine surgery. For example, we give instructions for people where they could bath that differ from 7 days to 6 weeks, office work from 6 to 12 weeks, and impact sports from 3 to 9 months, a large degree of variation. I think as a physio profession we can optimise this, and I'd urge you all to look at your own professions to see where you can optimise the information and the interventions that you give your spinal surgery patients. So, in summary, I hope I've given you an introduction to enhanced recovery for those who are unfamiliar with the subject. I've given you the underlying principles of enhanced recovery and the key components that are related to enhanced recovery. I've given you some examples of when that's been applied in spinal surgery with a key link to the lumbar spinal surgery ERAS guidelines. And I've also been reflective on my own practice and my profession's practice to show where we can make improvements, with the aim that us all as practitioners, depending on what discipline that we're in, can reflect on our practice and see where we can improve things for our patients in the future. Thank you for your attention. I'm happy to take any questions, and please do contact me via Twitter or email if you have anything after the session. Thank you.